Thank you very much for that very kind introduction. I would like to thank Novartis for inviting me and providing me the opportunity to speak here in Taiwan. Actually, the opportunity to speak in Taiwan was something I really was very excited for. Um, I, as everyone can tell, am American, but my grandfather was a doctor in Pingtung, and my dad was a doctor before in also in Pingtung before coming to the United States in the 1960s for his advanced medical training, and then stayed in the United States. And my mother is from Tainan, and so they all came to America, and I was born in the U.S. And they are still in Virginia, where I was born and raised, and they are very, very happy to know that I've come here to Taiwan to share my experience. Hopefully, that will allow you to help take better care of the cancer patients here in Taiwan also. It's also very interesting to be at a meeting and actually everyone knows how to say my last name better than I know how to say it. But I don't know any Mandarin. David might know more Mandarin than my Taiwanese is pretty good if it has anything to do with food or housework, but nothing about science. So this will be entirely in English. And so I'm going to talk to you about the theranostics for prostate cancer, the current evidence and future developments, a real landscape of the trials that we have going on. So these are my disclosures. I do a lot of consulting work for a lot of companies, as said, designing and executing theranostic trials from all over the world. And so prostate-specific membrane antigen, this is our target, all right? It's actually not a great name because antigen doesn't really tell you what it is. It's an enzyme, okay? So it's a transmembrane enzyme. This works remarkably well. So this is a transmembrane enzyme, and the other name for it is that enzymatic name, if you will. It's glutamate carboxypeptidase, and actually the protease site is right there. And so the idea is that a prostate cancer cell, which we know can express 100 to 1,000 times more of this enzyme on its surface than a benign prostate lesion would, or a normal normal prostate cell would. And with all that extra target on your cell, if you give a targeting molecule that binds tightly to it, and in this case, PSMA 617, you can then deliver therapeutic levels of radiation to kill the tumor. So we are here today because the phase 3 trial, the VISION trial, that gained this approval had very good results, and in March of 2022 got approved in the United States. A lot of people think of it as the date that Pluvicto got approved, but it's also important to remember it was the date that gallium PSMA 11 for selection of patients for Pluvicto was also approved. And that is a real recognition by the US FDA that this was a theranostic protocol. You do the imaging with the PSMA PET agent and use that to select patients for the therapeutic lutetium PSMA 617. So simultaneous approval on the same day in recognition of that theranostic paradigm. So one of the reasons you want to know about the VISION trial in greater detail is that the prescribing information by the FDA, which is being mirrored by a lot of regulatory health agencies around the world, really closely followed the VISION clinical trial protocol. And first of all, what is the patient population? It's the patient population that doesn't have really many good alternatives left. They've already failed taxane-based chemotherapy, which is usually docetaxel or cabazitaxel, and also failed an androgen receptor pathway inhibitor, which in the US is usually abiraterone or enzalutamide, or both in some patients. So this is an image of lutetium PSMA 617, okay? You can actually image with lutetium PSMA 617, and this is the image. And so, as you can see, the kidneys are the ones that have the highest activity, okay? And it's predominantly renally excreted. So your kidneys are really what limits the dose as far as the regulatory health agency is concerned. But you also get GI activity, as you can see. It gets excreted from the liver into the bowel. You get salivary and lacrimal activity, and the salivary activity is very important, so remember that in your image. And an important negative is you get very little normal marrow uptake, okay? So it makes it safer from the hematotoxic standpoint, but not completely safe, as we will talk about. So a lot of people get confused in a theranostic paradigm. You could potentially use the exact same molecule for the therapy and the imaging, but that was not what was done in the VISION trial. Okay, so lutetium PSMA 617 here in this is the therapeutic molecule, and you will put the beta emitting particle lutetium here, and the imaging agent was PSMA 11, in which you put the gallium 68, which is the PET isotope right there. But why is the PSMA 11 such a good surrogate biomarker for this PSMA 617 for the amount of expression you have of PSMA on your cell surface of your prostate cancer cells? Is that they have the same binding moiety, which is in the green oval, okay? And they have this common urea core, if those of you remember your chemistry, and this is a glutamate molecule over here, glutamate peptide here, which is why I reminded you that this is actually an enzyme. It's a glutamyl carboxypeptidase, so that actually binds into the binding site of your enzyme. So this similar binding sites is why you actually have very good similar imaging distribution with these two agents. So lutetium-177, because I know not everyone here is a nuclear medicine physician. It has a physical half-life of about a week, a little less than a week. So about after a week, whatever the isotope, if it's just sitting on your desk, half of it will be gone. But of course, when you inject into the patient, most of this will be cleared out by the kidneys well before that time, okay? That gives off beta particles, with the most common one being at about 500 keV, which is generally in the mid-range for our beta particles energies. And it also gives off gamma photons of about 200 and 100 keV. And that's how we were able to get that image I showed you of the whole body. Okay, so if there's any trainees in nuclear medicine here in Taiwan that are maybe remote or here, a good way to remember this for your boards is 7, 500, 200, 100. Okay, so it's got a 7-day physical half-life of 500 keV beta and 200 and 100 keV gamma rays. So something there for your trainees. Now, the VISION trial had this protocol. We're going to summarize it very quickly. Again, the patient population had to have received already 1 to 2 taxanes regimens and failed 1 or more androgen receptor pathway inhibitors. And we will get to it in my talk after David's, the PSMA PET selection criteria that was used, but that will be in the next talk. They were randomized 2 to 1 to either receive standard of care alone or the lutetium PSMA 617 plus standard of care. So this was technically a combination protocol. Most people just say the lutetium PSMA 617 arm, but it was actually lutetium PSMA 617 plus standard of care. There were actually 2 alternate primary outcomes. Overall survival was the initial one, but we were able to get back to the FDA and actually add as a primary outcome radiographic progression-free survival. And the reason we're talking about it and why it got approval was the RPFS had a hazard ratio of 0.4. And if you're a regulatory health agency, of course you care about the hazard ratio, but you actually also care a lot about the upper end of the hazard ratio, and it was 0.57, right? So still well below 1, with an improvement of just over 5 months in the RPFS. Now, the overall survival is what the oncologists are really also interested in, of course, and that had a hazard ratio of 0.62. The upper limit was 0.74, so still well below 1, and an improvement of 4 months in the median overall survival in this patient population that really has exhausted all your standard treatment regimens, already received chemotherapy, and an androgen receptor pathway inhibitor. So here was the Kaplan-Meier curve, so the imaging-based progression-free survival. As you can see, it's a wide gap. And the overall survival curve, okay? And one of the things I like to point out about this Kaplan-Meier overall survival curve is, remember, your last cycle, your 6th cycle of lutetium PSMA 617, so you get 6 cycles, up to a maximum of 6 cycles, 6 weeks apart. So your last cycle is right about here. But as you can see, the improvement in the overall survival extends well beyond even the last cycle that you would have received. A lot of patients care and should care about time to first skeletal event, which is defined as fracture or needing orthopedic fixation or radiation therapy to prevent a pathologic fracture. And that was greatly improved, okay? Because there was questions about, well, would it treat the bone metastases as well as the soft tissue metastases? And this is a good indication that the bone metastases are still treated effectively. As you can see, a good median improvement, 11.5 months versus 6.8 months. But there's still room for improvement. We have to be honest with the data, right? So standard of care arm alone, as you can imagine, didn't have very many PSA 50 responses, only 7%. And while the lutetium PSMA 617 plus standard of care arm had much better at 46%, about half, that's still, 50% of patients that did not achieve a 50% decrease in their PSA using the serum PSA biomarker. We can't talk about all those good results without some of the AEs, okay? So quick reminder, AEs grade 1, 2 are considered mild and moderate, and grade 3 and above are severe or life-threatening. Okay, fatigue and dry mouth was common, okay, but the vast majority were grade 1 and 2. As you can see, particularly xerostomia, remember the image I showed you, the lutetium PSMA 617, it does go to your salivary glands, unfortunately, and dry mouth occurred in 39% of patients with the lutetium PSMA arm, and only 0.5% with the standard of care arm alone. So very specific adverse event with the dry mouth, as we'd expect, because we know we're radiating these salivary glands. But fortunately, none were grade 3 in the VISION trial. You have to monitor your blood counts, right? Because you hit your thrombocytopenia and lymphopenia and leukopenia, so that does occur. Even though there's little normal marrow uptake, it's still radiation. Your bone marrow is very sensitive. And of course, a lot of patients had bone metastases, and that uptake in the bone metastasis will irradiate the adjacent normal marrow. 12% of these adverse events led to discontinuation of lutetium PSMA 617, and similar rates of AEs leading to death, 3.6% in the lutetium arm and 2.9% in the standard of care only arm. One important thing that I don't think you necessarily have to talk to your patients about this, but I think you need to know is that when you look at these adverse event percentages and numbers, the median duration in which the adverse events were monitored for in the treatment arm was 7.6 months. And in the standard of care arm, the median number of months was only 2.1 months. So they only asked about these adverse events in the standard of care arm for only about 2 months, a third of the time that they did for the treatment arm. So just so you know, these adverse events, it's certain you have to present them this way because you must, but the duration of assessment time between the treatment arm and standard care arm was quite unequal. So all this improvement in your overall survival, does it come at a cost of quality of life, right? Because we know with chemotherapy, you get a lot of toxicities. But as you can see, the improvement in quality of life also favored the lutetium PSMA 617 arm, okay? And specifically when it comes to quality of life, the pain scores were also in favor of the lutetium PSMA 617. So thankfully, we not only have an improvement in survival, but also in quality of life and pain, which of course is super, super important. You don't want to sacrifice quality of life. So I will be talking about this more in my next talk, but just as a little prelude, the patient selection criteria in the prescribing information by the US FDA also included the PSMA PET selection criteria, essentially word for word what we did in the VISION trial. Now let's take a look at the landscape, the roadmap of where we are going with targeted radioligand therapy and prostate cancer. And it's just not only in the metastatic castrate-resistant prostate cancer setting, it's throughout. So I don't want you to read this, this slide, okay? But going from left to right, this is local disease, biochemical recurrence, then going to third line metastatic castrate-resistant prostate cancer. As you can see, there are clinical trials in every setting of prostate cancer, from biochemical recurrence to hormone sensitive, even to MCR-PC. And highlighted in yellow are the phase 3 trials. So we have phase 3 trials even going on in the biochemical recurrence setting, not just, and MHA-PC and metastatic castrate-resistant prostate cancer as well. So let's talk about the most advanced phase 3 trial in that space right now, and that's PSMA-4. Okay, this was presented by Oliver Sartor. I am not one of the authors here, so I want to thank Dr. Oliver Starter and his authors and Novartis for allowing me to present this to you. But this is a pivotal trial, and the next endpoint will probably be reported out later this year. I think maybe at ASCO, but Novartis can tell you that. So PSMA-4, what is the patient population here? It is patients who have not received taxanes, okay? So remember, vision, they had to have received taxanes. This is before they received taxanes, okay? They were allowed taxanes, neoadjuvant, because in the US, we give it really early sometimes, but at least not in the MCRPC setting where they received taxanes. The selection criteria for the PSMA PET scans were quite similar to that used in vision, and they were randomized 1-to-1. You either got lutetium PSMA 617, again, 6 weeks apart, 6 cycles, just like in vision, or you got changed to an androgen receptor pathway inhibitor, okay? So if you had abiraterone before, you get enzalutamide. If you have enzalutamide, you get abiraterone. Going from enzalutamide to abiraterone usually doesn't work very well. Okay, one of the very important details about this study is when you failed with the ARPI change arm, you were allowed to cross over and then get the lutetium PSMA 617. Why did we do this? Well, not we, the people designing the trial. Honestly, it's a lot of people thought it was unethical to not allow these patients to cross over. Okay, so, and indeed, as I'll show you, 85% of patients after they failed the ARPI change went on to get lutetium PSMA 617, which shows you what high demand and how patients are really quite educated about lutetium PSMA 617. So the second interim analysis point has been hit, and that's what I'll show you right now. The third interim will be presented later this year. All right, so as you can see, 85% of patients actually already crossed over to the lutetium PSMA arm, and the primary endpoint in this study is radiographic progression-free survival. Overall survival cannot be your primary endpoint when you allow 85% of your well, not allow, but 85% of your patients cross over to get lutetium, because then everyone gets it, practically speaking. So you cannot have overall survival as your primary endpoint when you're designing a trial like this. So radiographic progression-free survival is defined by Prostate Cancer Working Group 3, was the primary endpoint. And that is accepted by the FDA. It has been accepted by the FDA as a primary endpoint for many, many years and for many, many trials. On the initial analysis, the hazard ratio is 0.4. In the updated, the second time point, it was 0.43, with the upper end of that confidence interval at 0.54. So very confident. You can see the curves. There's a wide gap between the PSMA 617 arm and the ARPI change arm. All right, I'm just going to go through this very quickly, but these are the secondary endpoints, okay? Overall response rate, PSA PSA decline, time to skeletal advance, quality of life. All of these also read out in favor of the lutetium PSMA arm. Okay, but we do need to show you this overall survival. You can statistically adjust for crossover. Of course, it's not as good as having a trial without crossover. And that has a hazard ratio of 0.8. But as you can see, the upper limit with that is a 1.33. So hazard ratio is less than 1, but the confidence intervals are really, really wide. Okay, so there were treatment adverse events, of course, and these are the ones that are greater than 10% in either arm. And again, not surprising, because we know that the salivary glands are hit by lutetium PSMA. Dry mouth was in great excess of that seen in the ARPI change arm. But other things like weakness, nausea, anemia were all higher in the lutetium arm. Fatigue was actually pretty similar between them, and you can see listed. It's an interesting sign of the times, and now we list COVID-19 as an adverse event in our clinical trials. So, in summary, the PSMA-4, lutetium PSMA 617 prolonged rPFS, the primary endpoint, versus ARPI change. The secondary exploratory endpoints investigated in this trial also were favorable to the lutetium PSMA 617 arm. The pre-specified crossover adjusted overall survival, which is a statistical analysis, had a hazard ratio of 0.8, but wide margins for the error bars. And the lutetium PSMA 617 had more AEs, but had generally considered a manageable safety profile. Another phase 3 trial that you should be interested is not as far along in the readout phase as PSMA4 is PSMA addition. And this is in the metastatic hormone sensitive prostate cancer space, okay? So Vision was not only MCRPC, but post-taxane, post-APR, ARPI. PSMA4 is pre-taxane, okay? And PSMA addition is now metastatic hormone sensitive. So we're moving into the metastatic hormone sensitive space with PSMA addition. And this graph is to show you that we have RLT trials in all sorts of phases of development, phase 1, 2, 3, 4, and a lot of them are in phase 2, as you can see in the blue. Let's talk about one in the phase 2 that you might be very interested in. I'm actually involved with this one as well. It's called PSMA Care. And I think a lot of the medical oncologists and urologists in the room will be very interested that we're doing this trial. So this is answers or will help us to answer a question that is not answered in PSMA4, which is what if you add lutetium PSMA 617 plus androgen receptor pathway inhibitor. Remember, PSMA4 was either one. So in this one, you have the lutetium by itself or lutetium plus standard of care, which is enzalutamide or darolutamide or apalutamide. Okay? So this will help us to answer this question. The patient population is a little bit different. You know, in a lot of places around the world, if you have metastatic disease by conventional imaging, you're going to have to get a taxane. So this is actually negative metastatic disease by conventional imaging, but we are allowing people to have metastatic disease by PSMA PET, which shows you that the world of sort of staging and clinical trials hasn't quite caught up to what PSMA PET is offering us yet. And another trial that I had nothing to do with, but I'm very honored that Louise Emmett and her co-authors allowed us to present. This is ENZA-P, okay? Very, very interesting trial with a lot of really interesting features. And it points out one of the very interesting biologies that we hopefully will be able to take advantage in the future, which is when you put patients on an androgen receptor pathway inhibitor, in this case, in this image, it's enzalutamide, you can upregulate the PSMA expression, okay? So in this image from Dr. Emmett, this is the baseline PSMA PET scan, and 9 days after enzalutamide, you can see more of the disease because you've upregulated the PSMA expression. There's a link between the androgen receptor pathway and the PSMA pathway. So in ENZA-P, you either got enzalutamide, which was the standard of care for this patient population, or enzalutamide plus lutetium PSMA 617. The additional thing that they did that was very interesting, which is what they call adaptive dosing, okay? So they do a baseline PSMA PET scan, okay, a baseline sometime in the past. And then at day 15, okay, so basically 2 weeks after starting enzalutamide, they do another PSMA PET scan. So this is to help them to quantify how much upregulation of PSMA you're getting from the androgen receptor pathway inhibitor. Then they give the patient 2 doses of lutetium PSMA 617, okay, and then they do another PSMA PET scan. And then from that new PSMA PET scan at day 92, they will decide whether to give a 3rd or 4th cycle. So if the patient's completely responded by that, they may not give cycle 3 and 4. If they've only had a partial response, then they'll give cycle 3 and 4. So very interesting design with a lot of interesting new aspects to it. And this is their data thus far. Their primary endpoints were PSA progression-free survival. You see this hazard ratio of 0.43, and radiographic PFS was also favorable at 0.67, although the upper limit just crosses 1. And there'll be further readout from this quite soon, actually. This is the PSA response rates, which are pretty darn impressive. The PSA 50% response rate was 68% with enzalutamide and 93%. But if you look at the PSA 90% drop, it was 37% with enzalutamide and a little over double that with enzalutamide plus PSMA at 78%. As you can see, though, the adverse events, there's some pretty specific ones, again, as you can imagine, to lutetium PSMA, but not too different, actually, between the arm. So in conclusion, they think it's very promising, not only this potential upregulation pathway using the androgen uh, receptor blockers first, but also potentially this adaptive to maybe spare patients these adverse events that you might see by going more doses than you need to with the lutetium PSMA 617. And now, again, for those urologists in the audience, want to show you an example of something called the lutectomy trial, where this is neoadjuvant. So we're going all the way to the very beginning of prostate cancer treatment. And another trial out of the Australian-New Zealand group. First author is Epen, and many of you may recognize the name of the senior author here, Dr. Michael Hoffman. And patients who had high-risk features, PSA greater than 20, for example, present, and they're going to have surgery. They get lutetium PSMA. There was actually 20 men who got it. In the first 10, they got 1 cycle of lutetium PSMA 617, 5 gigabecquerels, so a little less than what we give in Vision and PSMA 4. And the second group of 10 got actually 2 cycles 6 weeks apart. And then they went to prostatectomy, and the primary endpoint was actually your dosimetry. So this is really quite an exploratory early study. And here's for example, one exemplary patient where even after the first dose, the PSA dropped a lot, and after the second dose, it dropped even more. And it's hard, maybe you can see from the back, or those in the front row, this tumor actually had quite a bit of necrosis, presumably from the prior radiation treatment. And you get these significant decreases in PSA just from the neoadjuvant lutetium PSMA 617, with maybe a trend to maybe more of a drop in lutetium and PSA if you give 2 cycles of lutetium PSMA rather than just the 1. Okay, in addition to lutetium PSMA 617, there are other radioisotopes. Lutetium is a beta emitter, so is I-131, but we also have alpha emitters like thorium and actinium. Alpha particles are helium atoms, okay, helium nuclei, instead of the beta emitters, which are electrons, so they're much more massive, and they have a different mechanism of cell kill. So for those of you not nuclear medicine physicians, even though they're both ionizing radiation and particulate radiation, just like chemotherapy is not the same, different kinds of chemotherapy have different mechanisms of toxicity and different ways of killing tumor cells. Beta particles and alpha particles have different ways of killing tumor cells, okay? So they can be synergistic. You develop resistance to one, you can still be treated by the other. And ACTION is a trial using an alpha emitter, actinium-225, and it's the same PSMA 617 molecule, but instead of lutetium, we put in actinium-225. And this is actively recruiting. And there are several PSMA-targeted radioligand therapies, which are in clinical development, also in a bunch of prostate cancer settings, not just PSMA 617, but there's antibodies being developed. Antibodies have actually been used in prostate cancer imaging and therapy actually for decades. But other small molecules are also being tested, and one of them is Satisfaction. So it's another alpha emitter trial. It's the same actinium-225, but instead of PSMA 617, it's PSMA R2. So a different molecule, a little bit different biodistribution. And one of the things I want to point out about Satisfaction, which I'm actually helping out in as well, is that there's 2 arms. One arm is actually treating the patients who have failed lutetium PSMA 617, okay? Because that's why I told you it's a different mechanism of cell kill. So even though you failed the lutetium PSMA 617, you may be successfully treated with an alpha particle targeting PSMA radioligand therapy. But there's also a second group, which is going after the patient population who have not previously received the lutetium PSMA RLT either. So looking at pre and post lutetium PSMA RLT. And there's also many trials going on in combination. Okay, so there's monotherapy, combination therapy with standard of care, but combination therapy with some very interesting other things. The radiation oncologists in the room will know there's ones that are combining it with stereotactic body radiation therapy, and one's combining it with immunotherapies, which is very, very hopeful that we can actually affect even much longer term cures in combination with immunotherapies, because otherwise, as many of you know, prostate cancer generally does not respond well to immunotherapy. So a lot of people theorize that the antigen release that we can get from these targeted radioligand therapies can hopefully boost the immunotherapy response. So thank you very much.
Thank you, Philip, for the wonderful talk. And we are allowed for one question from the floor. Is that anyone want to have a discussion or something to ask?
It's a little ironic that now that we have advanced PET imaging, they're still using prostate cancer working group 3. So any comment on that? I understand it's well established, but it might be well established wrong now that we know more things, right?
Right. No. Absolutely. So, David, great question. And, it's really hard to break the momentum of something that works, right? And prostate cancer working group rules are actually established with the regulatory health agencies, because if the regulatory health agency doesn't buy into what you're creating, it's pointless. So prostate cancer working group 4 is well underway. I'm actually part of the group, and PSMA PET will be in the imaging component of prostate cancer working group 4. But there's a lot of considerations. It's not as easy as you might think, because you don't just want to keep adding imaging modalities and adding costs and adding extra time points. So you hope to kind of take away something too. So we'll see what the final version says, but hopefully we can. I think everyone wants to replace the technetium bone scan. So that's one thing. I think no one would complain if we got rid of the technetium bone scan and replaced it with the PSMA PET. But obviously there's a lot of added costs. And as you know, there's not a universal consensus on how to the response. And it's with these prostate cancer working group rule criteria, just like in 3, the RPFS should have the confidence that it would correspond to an OS. Okay, so that's very hard. So, but fortunately, the data's been building on that. And I don't want to steal thunder, but Dr. Michael Hoffman will be reporting on that in the second half of the year on the progress of prostate cancer working group 4 and the PSMA PET criteria.